Welcome to Clinical Conversations, a Journal Watch podcast. It's for the week ending February 26th, and it's podcast number 76. For links to earlier podcasts, go to podcasts.jwatch.org. I'm Joe Elia. Welcome. Today's conversation is with two researchers who are studying the most effective ways to communicate with patients, especially when the communication has to include the word no. First, a look at the current clinical news. Rosiglitazone, Avandia, an article in the New York Times, plus the issuance of an advisory on the cardiovascular risks of thiazolidinediones, has put the drug in a spotlight. The science advisory is free, and we link to it from the website. Next, your work hours, if you hadn't noticed, have decreased an average of about 4 hours per week over the past decade. I know you're all enjoying the time off immensely. Next, two pieces of vaccine news. The first is that there is a new 13-valent pneumococcal vaccine approved by the FDA, which is 6 valents is better than the current 7-valent vaccine. It will cover almost all the serotypes out there. The vaccine needs to be given on a 4-dose schedule. Also vaccine-related is the advice from the CDC's Advisory Committee on Immunization Practices that everybody, except for infants under 6 months of age, should get vaccinated against influenza starting with the next flu season. And by the way, the new seasonal flu shots will incorporate the 2001 H1N1 strain, which emerged too late to be included in this year's shot. Finally, if you know people who do cognitive behavioral therapy, you might consider referring your low back pain patients for a little group therapy. It seems to work both clinically and as measured by cost effectiveness. The study appears in Lancet. That's it for the news. Let's go on to the interview. You're listening to Clinical Conversations. This week, the Archives of Internal Medicine published a study of how primary care physicians deal with inappropriate requests from their patients, specifically for antidepressants. The researchers used standardized patients to make the requests, and the encounters were audiotaped surreptitiously. The clinicians had agreed to participate in the study, but did not know who the patient actors were or when they'd show up. After the visits, the transcripts were analyzed. I've asked the first authors of the study to talk with me about their work and its implications for clinical practice. Dr. Deborah Paterniti is a medical sociologist, and Dr. Tanya Fancher is an internist, both from the University of California, Davis. Welcome to both of you.
Thank you.
Dr. Fancher, I want to begin with a question that you didn't study. There were roughly 200 visits with inappropriate requests for antidepressants, and yet over half the requests were honored, and this among clinicians who were alert to the fact that they might be being monitored. Is that, do you think, a kind of good baseline for when a patient comes in and makes a request for something that they've heard about or something they think they might have? Do you think about half the time clinicians just cave and say, sure, all right, try it?
That's a great point. And I would say that, I think that is accurate. That original study that Rich and Deborah were part of looked at what would be marginally appropriate treatment for depression. So simply asking for an antidepressant or asking for a specific antidepressant was what they were looking at. And clearly, I think, when patients come in and ask for things in particular, that we clinicians try really hard to find ways that would be okay for the patient to have. Again, I think that most of us are in this because we care about people, we want them to get better, but we also want them to, we recognize that it goes beyond sort of just their medical care, but the social aspects of care are important as well. So I think that we default to try to do what the patient feels like is appropriate. So I do think that baseline is appropriate. Deb, I don't know if you wanted to add anything to that.
And I agree with Tanya from my studies of doctor-patient interaction and communication. Doctors want to not only engender trust, but maintain trust throughout their relationships with their patients. And sometimes maintaining that trust means giving the patient what they want. It may not be the first choice in the mind of the physician in terms of what they might want to do for the patient, but as long as it is not dangerous, it's not unindicated or inappropriate treatment, as long as it is sort of minimally appropriate care, then physicians often do default to giving patients what they want and what they request.
That's fair enough. So people's intentions are good, and so what you studied really in depth here, and I'll put those inappropriate fulfillments aside. What you studied were the people who said eventually, no, you can't have this antidepressant. Most people didn't say it in that way, but let's talk about the people whose requests were denied. What were the strategies that clinicians were successful at using to say no? Dr. Patroniti.
Well, the physicians used really three overall strategies. One was outright rejection of the request, and they used that outright just, no, I don't think so, and moving on to a different topic, or no, and then changing the subject. They used that in 5 of the 84 cases that we studied. Mm-hmm. Then they also used referral for diagnostic workup or biological tests. And then the most common strategy we found, though, was the use of the patient's own narratives, the patient exploration of what the patient had to say with regard to making the request. Mm-hmm. And that is probing further into why the patient was making the request, what kinds of things were bothering them, what their viewpoints were, what sorts of things were under the surface of that request. And when physicians asked about why patients were making the request and explored some of those reasons, and then used what they heard from the patient to explain why they were not fulfilling the request, that even if the request went denied, our standardized patients who went into physicians' offices reported higher rates of satisfaction with their physician visit than those standardized patients who had request denial that was biologically based or an outright rejection. So when physicians explored the patient's reasons for making the request and used that to tell the patient, fed it back to the patient, tell the patient why they were saying no, patients had higher rates of satisfaction.
And so it sounds like the more that the patient felt engaged with the clinician, the better they felt about whatever the decision was. I guess the best feeling comes when you go in there looking for something and you get it. So that's everybody's default. But if you go in there looking for something and the patient, as I was reading your paper, the clinician says to the patient, well, maybe you've got another diagnosis here. Let's think about that, or let's explore, as you said, what your reasons are for asking for an antidepressant. Or maybe what you need is a referral to a mental health professional. Those things scored higher than the clinician who says, I don't think so.
Right. And they also scored higher than the clinician who said, well, let's refer you to labs and draw some blood and do some tests, and then you can come back and talk with me.
Okay, so it's the personal approach that seems to be working best here.
Right. It's meeting the patient where they are.
Dr. Fancher, what's your reaction to the results?
You know, as a person who's involved in this sort of communication research, I was pleasantly surprised to see that that's when patients were happiest, was when we as clinicians take the time to ask them. I guess I was surprised at how it was less frequent for the physicians to order a lab evaluation or to prescribe a sleep aid. It seems, maybe because I work in a residency program, I see that a lot with junior clinicians, that what they want to do is because they feel so pressed for time, it takes a lot of time to talk to patients, that often what they'll do is prescribe something that seems almost as fitting, but not quite an antidepressant, or they'll order labs. So I was surprised that happened a little less commonly. And I think for clinicians in the real world, with this feeling that everyone is so busy, and it feels like it takes a lot of time to really ask where the patient is coming from, that making that part of our workup, part of our collaboration, even with counselors who are sometimes just down the clinic from us, thinking of counselors as our collaborators, that patients really appreciate that perspective more than feeling like they're being dismissed when they're sent to a counselor.
So are there other areas of research, and I know that you can't be disclosing results early or anything like that, and I'm not asking you to, but are you pursuing this general area of research in other ways? And I'll ask Dr. Padroniti.
At the current time, we do have some studies underway looking at depression, and with Dr. Kravitz, who is the senior author of the article. We do have some studies underway looking at depression and whether or not finding ways to prime patients, give patients permission to talk with their doctors about depression, actually makes patients disclose depressive symptoms or bring up the fact that they've been feeling depressed with their doctor. So that's in process now. I think there are other interesting questions too, and that is the question of whether or not these strategies for no hold when a patient asks for a specific procedure or a referral to a specialist, and those are areas that are untested.
And those are areas, for instance, referral to another specialist or for a CAT scan or something like that.
Right. Right.
Those are exactly the things that especially clinicians working in institutions are probably going to be encouraged to be very vigilant about. Is that right?
This is Deborah Padroniti. We can also ask the question, though, is more care better care? And there are lots of studies and lots of countries' health systems that suggest it is not.
There was a recent article in the New Yorker exploring that very question in Texas. I think it was
Correct.
Atul Gawande's article.
Yeah. Yeah.
So it sounds like both of you have read that.
Yes.
Yeah.
Do you think it's
It should be required reading, I think.
You think it should be? I think I'll put a link to it on the website, because I think especially for people who are starting out in medicine, it's a nice introduction and a nice narrative.
Yes, I mean, it's a fabulous eye-opener, too. I use it in my classes.
So, Dr. Fancher, next week, when after people have listened to this interview over the weekend and they go into their clinics, what do you hope that they will do differently than they were doing this week?
I hope that after, if they come under the circumstance where a patient comes in and asks for something in particular, that the next question would be, tell me more about your reasons behind that, or help me to understand why you feel like you need whatever X is. That, I think, is the first step.
So, talking with a patient as opposed to writing something down like a referral or a lab or just saying no. Let's get on to the rest of the exam.
Exactly, what you learned the first day of medical school. Right, go back to that.
Dr. Padroniti, given those constraints that we talked about on the healthcare system, what do you think the implications are that for patient behavior?
I think the implications for patient behavior, they're going to start making more requests, given constraints on the healthcare system. The requests from patients began to increase with consumer health movements in the 80s. They skyrocketed with direct-to-consumer advertising in the 90s, and I think that in 2010 we're faced with this healthcare crisis. I think we're also going to be faced with people who are anxious about getting care, feeling like they're going to be denied care, and they're going to start asking for more from their health care providers.
I think that's a good observation, and I think that anything that helps clinicians deal with that is going to be very useful clinically, even more so than some of the tests that they may not be able to order so easily now.
And I also would like to point out that different patients have different preferences or styles of communication or ways they'd like to approach things. There are patients who actually want tests more than they want to be referred to a mental health advisor to talk about what's underlying their issues. Some of those differences are gender-based or based on ethnicity and background. So I think what our paper really provides is not only the lesson that Tanya was talking about with regard to, talk to your patients about the reasons underlying the request, but it's also nice to be able to hand over to physicians a list of strategies for saying no to patients who might have different preferences for treatment and for styles of communication.
It sounds like an article that somebody on this call might write. All right. Well, Dr. Padoniti and Dr. Fancher, I want to thank you both very much for your time today.
So thank you very much.
That's it for this week. You can reach Clinical Conversations at 1-617-440-4374, or you can write to me, JELIA, at jwatch.org. Earlier podcasts are available at podcasts.jwatch.org, where links for all news stories can also be found. Clinical Conversations executive producer is Adoriano, and I'm Joe Elia. Join us next time, and thanks for listening.